Assalamu alaikum wa rahmatullah. Good evening. I'm Dr. Amber Khan, and we're here with the Education Committee for IMANA. Tonight, we have a very special webinar on advanced therapies in pain management. Pain management, it's a subspecialty that includes a wide variety of treatments, including medications, interdisciplinary collaboration, and interventions. In this discussion, we're going to highlight the advanced procedures that certain pain physicians may offer to treat more complex and difficult pain syndromes. It is a great pleasure from the IMANA community to invite tonight's speaker, Dr. Hassan Aboumehri. Dr. Hassan is an anesthesiologist and interventional pain physician. He practices primarily in the Cleveland area at University Hospital's Lake Pain Management. He specializes in advanced and durable pain therapies, including neuromodulation, such as spinal cord and dorsal root ganglion stimulation, and many others. Dr. Aboumehri is interested in continued innovation and meeting new challenges in the multidisciplinary field of pain medicine. And he is especially valued to us in the IMANA community because he's also chair of IMANA's Students and Residents Committee and carries a background in medical education and global outreach. On behalf of the IMANA community, Dr. Aboumehri, we greatly appreciate you taking time to share your expertise with us. Without further ado, we'll go ahead and pass it on to you, and you can begin whenever you're ready. Jazakallah.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Dr. Khan, for that very kind introduction. Thank you, Imana, for hosting this talk. My name is Dr. Hassan Aboumehri, and today we're going to be talking about almost a subspecialty within a subspecialty, and that's advanced therapies in pain management. So, Bismillah ar-Rahman ar-Rahim. Here we go. All right, so first of all, in terms of disclosures, my opinions, of course, are my own. They're not that of IMANA or University Hospitals or University of Chicago, where I also have privileges, or of any medical device company. A lot of the procedures that we're going to talk about, some of them are exclusive to certain device companies or certain companies, umbrella companies that own them in a proprietary fashion. So we'll try and be as general as possible when talking about these therapies. The objective of this talk is to really help the provider who often encounters chronic pain, right, and wants to have a better idea of what options are available. And that goes, beyond general pain management, which most of us are exposed to through our medical training. So we want to identify appropriate indications and contraindications for various types of advanced procedures. Ideally, the provider then, after this talk, will be able to recommend certain advanced pain management procedures and also be able to evaluate the effectiveness of certain procedures if they hear that their patient is considering them. Then they can provide a little bit more input. So the first big topic that we're going to talk about is neuromodulation. And I'll say up front, all the things that I'm talking about can be and are usually performed on an outpatient basis. Again, most of which, with clinical exceptions, are also done under MAC with the goal of trying to avoid general anesthesia as well, and basically making recovery as smooth and efficient as possible, again, with clinical exceptions. So neuromodulation basically refers to the use of electrical energy to modulate the nervous system peripherally or centrally to try and produce a clinical result. In this case, of course, we're talking about pain management using spinal cord stimulation, peripheral nerve stimulation, stimulation of the dorsal root ganglion, as well as some transcutaneous techniques. So we'll start off by talking with SCS, which is something probably most people at least have heard of. We're going to try to focus also on FDA-approved indications, although there are others beyond there. And I've also included some references here at the bottom of some relevant or landmark research papers, most of which are long-term RCTs, explaining the efficacy of these therapies and why we do them. But the most common, or at least the FDA-approved indications, are lumbar post-laminectomy syndrome, complex regional pain syndrome, diabetic neuropathy, and refractory low back pain. Off the bat, you can see that these are pain syndromes that are quite challenging to treat. A lot of these patients have already been through the ringer when it comes to conservative treatment. A lot of them have already had surgery, or perhaps they're not candidates for surgery. And again, that's the theme for a lot of these advanced procedures. The workup for this really is, of course, trying to be as conservative as possible initially with pain management. But if they don't have other alternatives, then SCS could be a great option. Generally speaking, I get thoracic spine imaging, not everybody does, to make sure that there's a canal that's patent in order to place the spinal cord stimulator leads in that area. But insurance also requires a psychological evaluation for these patients, mainly to make sure that they don't have any underlying mental health issue that could um, basically prevent them really from improving no matter what sort of therapy you might provide, especially in a therapy like this, which takes commitment. It's an implant, it's expensive. Um, but what I tell patients is just like going to buy a nice car and going for a test drive first before making that big decision, you can do a trial. So in this case, I can place percutaneous leads in the procedure suite, usually just with a little bit of IV, relaxation. And those then leads are come under connected to an external battery, and the patient can go home and try it essentially for a few days or a week. Usually I do it for about a week, and they can see how it affects their pain, their mood, their sleep, their functionality. And then at the end of the week, we can kind of talk about how much they liked it and whether or not they want to move forward with the implants. The limitations of the trial anyway, especially confounding soreness. You really want them to maintain some movement restrictions so those leads don't move out of place, so you can get a false negative, right? Because the leads have moved now from away from the target area of the spinal cord that we're trying to stimulate. And also they can't submerge underwater or get that area wet. So we talk about sponge bathing or using a detachable shower head to basically wash their lower body. The implant itself um, requires two incisions, one at the midline of the spine where the epidural leads are actually placed. And then there's another incision, usually made at the flank or the buttock, where the implanted pulse generator, the battery, is actually going to go. And then the leads are tunneled underneath the skin to that battery. Um, there's a lot of different nuance here with perioperative practices and comes to prep and post-op follow-up, but most will usually give some prophylactic antibiotics here to help prevent infection, and then those movement restrictions are recommended for 6 weeks post-op.
I apologize.
Peripheral,
I'm
yeah.
sorry. I apologize for interrupting. It doesn't seem like the slides are moving as you're speaking. Just want to make sure it's not happening on my end.
On my end, they're moving. Which slide do you see right now?
We're seeing the first one, which says disclosures.
Oh, that's not good. Yeah, I've moved a few slides ahead here. Let's see.
We got a comment in the chat that's saying that others are seeing it as well.
Sure. Let me see if I can. It says sharing. Let me see if I can try this again here.
Sure.
How about now? Do you see my slides moving?
Yes. Thank you so much. Appreciate it. Please
Okay,
proceed.
no problem. Okay. So now we're gonna move on to peripheral nerve stimulation. So here, we're talking about the use of a electrical lead, but instead of putting it in the spine, we're placing it over a target peripheral nerve to treat chronic pain. The indications are a little bit more vague in terms of definition, but that's also because there are so many different kinds of well, first of all, there's so many different peripheral nerves in the body and so many different kinds of pain that can occur as a result. Some is a combination of mechanical and nociceptive pain with nerve pain, and some is traumatic, some is not. Um, but essentially, if pain physicians able to identify a target nerve that is involved in at least a majority of the patient's pain syndrome, then you can stimulate that nerve peripherally to try and produce a result. Um, in this case, there's kind of two options. One is a lead that's actually just placed percutaneously through the skin. I try to do most of these under ultrasound guidance. Um, and it stays in the body for about 60 days, providing therapy. And then the studies show that, the patient can continue to get pain relief for a year or two out after that. And these things can be repeated if necessary. Or there's the alternative where you do a trial first, just like with SCS. And if the patient gets good relief, you can place a permanent one under the skin. And then there's different types of ways to stimulate that wire depending on the device company that you choose. Um, Again, the workup for most of these, you want to make sure that the patient has exhausted conservative treatment, and you discuss whether or not there's a surgical alternative that could provide resolution of their pain or treat the underlying problem. But if that's not the case, or the surgeon's not a candidate, or I'm sorry, the patient's not a candidate, or they absolutely want to avoid surgery at all costs, then it's where these therapies kind of come in. The challenges is kind of the non-standardization of these of the device placement because of the variation, again, in these kind of peripheral pain syndromes. And there's a theory of whether or not there's also retrograde stimulation. So you place a peripheral nerve lead, and it helps pain that's more proximal to where the stimulation is occurring. So there's definitely room for continued innovation in the field. Dorsal ganglion stimulation is involves placing a stimulating lead over the dorsal root ganglion, or the nerve synapse as they exit the spine. And the concept here is that your treatment is much more targeted in a dermatomal fashion, because there is much less cerebrospinal fluid between the lead and the actual nerve body. The much less energy is required to stimulate the nerve. And when it comes to FDA indications, I basically have a label of complex regional pain syndrome, and those are the levels that are indicated there as well. But the nice thing about it is, compared to SCS, there's a lower migration rate, there's a lower energy output requirements, and you get more targeted therapy, which also means more reproducibility between providers, but also between the trial itself and the actual implant. So it's technically a little bit more challenging, and it takes a little bit more time, but for a lot of patients, it's definitely worth it. So now we're going to move on to more what I like to describe as mechanical interventions rather than neuromodulation. The first one we're going to talk about here is a type of percutaneous spine decompression uh, called ligamentum flavum debulking. So essentially what this is, again, an outpatient procedure made for patients who have spinal stenosis with neurogenic claudication. So as a review, that's the patient who basically has nerve pain, maybe numbness, weakness, cramping, especially going down their legs, potentially the buttocks, with standing and walking. And oftentimes it's relieved with leaning forward. So you might remember maybe from med school or exposure during training, patients who kind of show that shopping cart sign, kind of needing to lean over to relieve their symptoms. Of course, if the stenosis is severe enough, they may also appreciate those symptoms while sitting down. But it's often worse when you stand up, because the stenosis in the spine gets worse. If you're able to identify ligamentum flavum hypertrophy, which is there quite often in the aging spine, that ligament is usually contributing to that stenosis. So the on-label treatment is people who have mild to moderate stenosis with that hypertrophy. Usually it's around 1.5 millimeters, greater than 2.5 millimeters is indicated. I mean, we're seeing 4, 5, 6, 7 millimeters oftentimes in the office and intervening on that. The effects are quite remarkable sometimes when you debulk that ligament, because we're talking about a narrow space within the spine. Once the patient overcomes that initial soreness from the procedure itself, which is usually done through basically a stab incision, they're able to stand and walk better, and you can see that pretty early on. Usually at that 2-week follow-up, patients are can start to notice a difference, but as they continue to learn to stand and walk better and straighter. Sometimes with the help of physical therapy, that pain relief can improve over the course of several months. Now, this is a different type of intervention for stenosis, here requiring an implant. So with interspinous spacers, the concept is that by placing an implant in between the spinous processes, you're able to indirectly decompress the spine or open up the spine, open up the canal, as well as the lateral recesses in the neuroforamina, without having to do a traditional spine surgery or remove large pieces of bone or having the patient to endure, a significant amount of recovery afterwards. Um, these incisions are quite small to place these implants, 4 centimeters max. And but you also want the patient to be able to withstand that sort of distraction of placing the implant. So generally speaking, patients with osteoporosis would be at higher risk of fracture. So sometimes, well, I personally get a DEXA scan prior to make sure that the patient, is a good candidate for this. But it's another tool that we have. And then this is I think the third kind of big advanced procedure that we do for spinal stenosis, again, to produce a definitive result for the patient who is not a candidate for traditional spine surgery, or frankly just doesn't want to go through that risk and recovery. Again, the indications are mild to moderate stenosis in this case. And the difference with this particular technique of posterior lateral arthrodesis is you avoid making an incision over the supraspinous ligament, which potentially could be providing more integrity to the spine. So by avoiding basically incising that as with the previous procedure and coming in from the side, you preserve a little bit of the spine's natural anatomy and integrity. And then instead of decompressing the spine through distraction in the cranial caudal plane, coming in laterally and then basically dilating and using sort of screw fashion to distract the spinous processes, you're potentially able to open up that space uh, in a similar fashion. There's been no head-to-head kind of studies in this case. The big difference here, though, is that um, uh, by using um, scraping away part of the spinous processes and placing some cadaveric bone material, you're able to encourage the formation of a fusion across. So it's also conceived that this is beneficial in patients who have listheses. So you're also stabilizing the spine with the placement of this device. Posterior sacroiliac joint fusion is another mechanical technique that we use for the treatment of back pain. Now, this is a different pain syndrome altogether. SI joint pain is often overlooked. It's pain that is more lateralized, usually compared to more axial low back pain. Um, Women are more predisposed to it, especially if they've been through childbearing. Patients who have had lumbar spine fusions are also more predisposed to it due to the shift in basically load over to the SI joints. And again, after maximizing conservative therapy, usually we would do SI joint injections, and when those wouldn't work in the past, spine surgeons could offer what's called a lateral fusion, where they come in from the side with like 3 large triangular rods. But that procedure, although it works, it tends to be morbid, and then patients have to be non-weight bearing for at least 6 weeks. With this posterior technique, where you're coming in from the back instead of from the side and placing an implant into the SI joint or bringing those two together with screws, then you get to avoid the risk of coming in laterally, the risk of bleeding, the risk of infection, and the long recovery that comes with that. Meanwhile, the distraction itself, the approximation itself, with these implants produce a really rapid results in these patients. And some of them, well, most all of them are supposed to encourage fusion as well, although each device kind of has its own technique to try and encourage that. Some, uh, like the image on the left, use uh, a purely cadaveric implant without any sort of metal, whereas the one on the right uses a titanium alloy. The goal again is to form a fusion there and help stabilize the joint better. Both of these fusion procedures, we want patients to minimize smoking, avoid steroids or NSAIDs. Yeah, everyone kind of has their own preference in terms of how long that should be done for, but the idea is that you want to encourage fusion, you don't want to counteract that. So this next one is basovertebral nerve ablation. This procedure, I have the picture. So this procedure is uh, is really cool in that it's able to treat kind of a more unique diagnosis of vertebrogenic low back pain, and that's pain that comes from basically chronic discogenic back pain. As the disease disc degenerates, you end up getting this persistent kind of like vague back pain. And in the past, surgery was offered for these patients, but without those leg or radicular symptoms, or without stenosis or some sort of compression causing radiculopathy, generally speaking, decompressions and fusions didn't really help with the isolated axial back pains. Um, if on the MRI you're able to visualize modic changes, you see the radiologist note basically inflammatory marrow changes in the vertebral bodies adjacent to the disc, then that's an indication, that that could be where the pain is coming from. Um, it's FDA approved from L3 to S1, and uh, the the procedure is also done through a stab incision, also under MAC, also completely outpatient. And the cool thing about this therapy in particular is that the long-term RCTs have measured these patients. Most of these therapies, have they followed patients, 2, 3, 4, 5 years out. This one has 5-year data showing that the pain doesn't come back. So compared to some of the other ablation procedures that we do, the nerve, because it doesn't have a myelin sheath, actually does not grow back. So it is a more definitive, more durable, and is a term that we use, sort of therapy for a pain that in the past was very difficult to treat and we really didn't have a lot of great options for. So I'm very happy to offer that as well. Vertebral augmentation refers to a group of interventions that we do to repair um, broken vertebrae, in essence. There's a couple different ways to do that. Vertebroplasty refers to just going into the vertebral body and placing cement at that broken vertebrae. Kyphoplasty refers to the use of a balloon to create a cavity first before placement of the bone, with the concept of restoring height. Um, and then spine jack actually uses jacks instead of a balloon to restore height in the vertebral body. Um, for the most part, right, I always prefer to do kyphoplasty in that osteoporotic patient because, again, you're trying to regain height and restore integrity at that vertebral body. The reason more to use spine jack is in the case of burst fracture rather than a vertebral compression fracture, but also in a patient who has, a more isolated fracture rather than, older osteoporotic female, for example, who may have multiple, because spine jack itself has a lower rate of contributing to adjacent fractures in the future. So it's a little bit more protective that way. When seeing these vertebral compression fractures on the X-ray, usually we'll try to get an MRI to try to assess the acuity of the fracture itself. So if you see more marrow changes on a stir, for example, then that basically reinforces that the bone is still healing and hasn't basically hardened completely, where a sclerotic vertebrae would be, first of all, more difficult to access, and second of all, it's questionable how much relief the patient's actually going to get from the procedure. Um, MRI is also useful in ruling out nerve compression or significant retropulsion back into the canal. So when patients come in, with a severe back pain, we after getting the imaging, these are the procedures that we review. And the main reason I think it's particularly important and is often overlooked is that, there's really robust evidence showing that this actually decreases mortality in a lot of patients. I mean, one of these studies looked at over 1 million patients. And the concept is, if someone's back's broken, they're going to be basically bedridden, higher risk of blood clot, infection, muscle atrophy, and worse. So I think it can't be kind of understated how important it is to try and identify these patients and treat them, within the first 3 to 6 months. And then another technique that I perform is vertebral tumor ablation. So this was indicated in patients who have painful vertebral metastases. Um, the best outcomes are really when used as an adjunct to radiation treatment, similar to basovertebral nerve ablation and vertebral augmentation. The vertebral body is accessed percutaneously using fluoroscopic guidance, quite tolerable under MAC most of the time. Outpatient, again, those last two parts, if clinically that's appropriate, and then the tumor is ablated itself, and then afterwards the created cavity is augmented with cement to reinforce that broken bone. And I've had a number of cancer patients with numerous metastases throughout their spine undergo this procedure and get relief quite quickly. So it's a nice tool for, again, patients who are dealing with some very difficult pain. And then the last thing I'll mention here is intrathecal pumps. Intrathecal pumps have been around for a while. Spinal cord stimulation was in its infancy back in the 60s here and has really come leaps and bounds in the last 10 years alone. Um, Intrathecal pumps themselves, have been around for a long time as well. And really, the most common use is in cancer pains who have a high opioid requirement, and as a result, they are basically dealing with a lot of side effects related to opioids, in particular, constipation. Um, but intrathecal pumps are also quite useful in patients who have certain intractable non-malignant pains. These patients are, identified more on a very much case by case basis, um, but it's kind of left up to the individual pain physician's clinical judgment. But the concept is you're using a fraction of the opioid dose that the patient will typically take orally, but you're yielding um, quite potent effects centrally and dealing with less systemic side effects, especially by avoiding the GI tract. There are 3 FDA-approved medications, and only one of them is an opioid, morphine, baclofen, aconitide. But there's a few other medications that are used more often that are technically off-label. Similar to committing a patient to a spinal cord stimulator, patients can undergo a trial or should undergo a trial first prior to the implant. Um, and that can be either done through a one-shot spinal outpatient, or it could be done through the placement of an intrathecal catheter trial, which is followed as an inpatient and titrated, throughout their hospital stay. Um, these pumps then have to be refilled every few months. As a therapy, it's been proven to be safe and effective in improving quality of life in advanced cancer patients. And again, these cancer patients, who are dealing with so much as it is, it's good to have these tools where a lot of conservative treatments can fail. So all in all, the takeaway is that chronic pain is really a variable, dynamic, and challenging thing to encounter in medicine. there's lots of different kinds, right? And lots of different types of pain, whether it's nociceptive or neuropathic or a combination, malignant or non-malignant. And non-opioid therapies, always the priority when you see a patient. You always want to maximize conservative treatment, and perform a thorough workup. But responsible opioid prescribing also remains a part of our specialty. I think as pain physicians, we remain stewards and responsible opioid prescribing. So I think we remain as resources in helping with that when it comes to chronic pain. Conventional interventions also remain useful, but they have their limitations. Steroid injections rarely last more than 3 to 4 months at a time, and oftentimes, with repeat injections, they may become less and less effective. Some patients, if they're working for them to get a couple shots a year, that's fantastic. But when those shots become less effective, or if they're really looking for something more durable and definitive, that's where these other therapies come into play. So I think it's helpful if non-pain providers can recognize the potential for these advanced therapies to try and address the underlying pain generator of the patient. Um, Meanwhile, the interventional pain space that we're currently in is going to be rapidly growing as it has, and we're going to continue to see more innovation and more definitive advanced therapies for patients who are really looking for a solution to their pain, and not just something that's going to cover it up every so often, which is very exciting. So thank you to everyone for listening. I wanted to plug the IMANA mentorship program, which is a really great program to help provide a network for um, aspiring providers who are at any stage of their career, whether it's a med student seeking to be connected with a resident with a fellow, or a fellow with an attending, and basically across the board. It's free and available, easy to access. If you have any questions for me personally, there's my email, and my socials are up there as well. And thank you once again. We'll take any questions.
Thank you so much, Dr. Aboumehri, for going through the many different options available. You really showed us there's a lot of variety here. Um, I think one thing I really noticed was that pain is a very big part of every medical professional. So to hear from somebody who works very closely and directly with being able to relieve that gives us a lot of insight on what we can offer to our patients. Um, Working with, or I imagine that patients who have been dealing with chronic back pain, they've tried over-the-counter meds, perhaps opioids, maybe dealing with some of those side effects. They're looking for some of these procedures for relief. What kind of advice would you offer a PCP who's seeing patients with back pain? Like, when do they know when is a good time to be referred to someone like you?
That's an excellent question. I appreciate your comments. Yeah, pain, being interventionalist, obviously I love interventions, but it is a very much a multidisciplinary field, and I think a key to being a successful pain physician is maintaining strong relationships with your primary care providers, but also with other specialists, and knowing when to talk to them, like your neurologist and your spine surgeon and your orthopedic surgeon and so on. I would recommend that, the primary care physician tries to employ, the initial non-opioid managements, whether it's anti-inflammatory medications, Tylenol, perhaps considering an oral steroid when they encounter chronic low back pain, and recommending physical therapy. And if those things don't improve, that's really a good time when the symptoms don't respond to that 4 to 6 weeks of physical therapy. That's really a good time to try and get pain management involved. And it's always great to order an MRI, which kind of really helps us with our diagnosis. It's also important to be vigilant for alarm symptoms. If a patient has worsening back pain and they also have fever, chills, or night sweats, you want to consider, infection. If they develop weight loss and they're having night sweats, you want to consider malignant etiologies. If they have new onset numbness or weakness in their leg, that's appreciable on exam, or if they have any signs of cauda equina syndrome, like loss of control of their bowel or bladder without the sense of urgency or saddle anesthesia, then those are patients really who should be assessed more emergently.
That's great, thank you. We do have a question here about the comparison between percutaneous over classic vertebral disc herniation surgery. When does percutaneous, when is that a good or a preferred option over that disc herniation surgery?
So I'm presuming we're talking about this procedure here in particular. I believe that if there's a disc herniation that is causing nerve compression, and that nerve compression is causing objective findings, and that patient has failed conservative treatment and injections, then that patient's going to be getting a surgery, and nothing's going to fix that issue except surgery. This procedure in particular, basivertebral nerve ablation, here we're talking about a degenerated disc that's not necessarily causing any sort of compression. We're not talking about patients who have radicular symptoms. We're talking about isolated back pain from a degenerative disc that is not causing compression.
Gotcha. Yeah, I think the percutaneous vertebral decompression was what they were referring to.
Okay. Gotcha. Yeah, well, in those cases too, again, these are meant for more mild to moderate pathologies. In particular, we're talking about stenosis. So these are pathologies that have also developed chronically over a slow course of time. Um, if you're talking about a disc herniation or a disc displacement that's causing radiculopathy, um, this is not what these are made for in particular, right? This is made for mild to moderate stenosis.
Gotcha. Okay. Now, as an anesthesiologist, what do you think is the hardest part of the work you do? You're working in extremely tight areas of nerves, and I imagine that a very common fear patients may have coming to you is the risk of paralysis. How do you get through working in these types of areas, and how do you address some of those concerns to the patients that you have?
Yeah, excellent question. Um, in medicine, almost everything we do always carries risks, and we have to be responsible in providing informed consent anytime we recommend a procedure to a patient. I try to make it clear that when I make a recommendation, it's because I believe that the benefits far outweigh the risks. But I always go over the kind of three big ones, which are bleeding, infection, and nerve damage. I talk about mitigating bleeding risk by making sure, reviewing if the patient has a bleeding issue and whether or not that needs to be assessed, holding blood thinners appropriately once we have the clearance to do so, and how we avoid kind of being close to any sort of blood vessels. With infection, if the site is infected or the patient's sick for something purely elective, we would just reschedule and make sure that that infection is addressed. And things that we do that have higher risk of infections, such as with SES implantation. We talk about prophylactic antibiotics. And with nerve damage, there are some things that we do that definitely carry higher risk of nerve damage compared to others. I try to make that clear, but I also talk about all the different things that we do to minimize that risk, such as taking frequent imaging, taking frequent images with the fluoroscope or with the ultrasound to know exactly where I am the entire time, and using those images to create a 3D space in my head to know anatomically, where I am. Sometimes using contrast to make sure that I'm also in a safe area and not close to anything, that would be particularly dangerous. But we always have to be vigilant.
Absolutely. Yeah. As we get closer to the end of our webinar, we just had one last question, which is, would you be able to share a story of a patient who you met who was dealing with a lot of pain and you were able to treat them, and just kind of how their experience was post-op and after, a couple of weeks of the procedure that was done?
Sure. I might have missed one part of your question. Is it in regards to a specific procedure or just anything in
Just
general?
in general, yeah, just one that comes to mind.
Yeah, sure. Um, so there's a lot of these stories, especially with the these elderly patients where I often hear like, I wasn't able to uh this is the first time that I've been told I have this diagnosis, or I didn't know I could get this done, or this is the first time that I've been able to hold my grandchild.
Mhm.
One recent story sticks out in particular, where um, this patient had some significant stenosis, and he tried everything, before he'd come to see me. He was a 80-year-old, I think, a Vietnam vet, and he had uh, experienced spine surgery in the past, which had helped at the time, but he ended up with this persistent back and leg pain later on. We'd been diagnosed with post-laminectomy syndrome. He eventually got a spinal cord stimulator, and I remember him saying, "Doc, I don't remember the last time I've been able to tie my shoes until I got this procedure done." And he like said it with like such a big smile that sometimes these like small activities, that we take for granted, um, subhanallah, you get humbled, with with what comes, with the aging process. And he got the stimulator, and he said, he can finally tie his shoes, and that's the one thing really that he wanted to tell me first in post-op. So he's really happy about that. So it's stories like that, I think, that make you feel like you're actually making a difference. With pain management, we often joke, we're saving patients' lives one epidural at a time, but really we're making an impact when it comes to quality of life, and helping protect and maintain functionality for a lot of patients.
Well, may Allah reward you immensely. There's a very common, belief that chronic pain is, heavily associated with suicidal ideation and just the feeling of even wanting to continue life. So to be able to offer a patient a pain-free life or reduced pain-free life is definitely not something to be belittled in any way. And may Allah, reward you immensely for the work that you do and continue to allow you to do it to the population.
So thank you.
Actually, I have one more question, if you wouldn't mind going over a little
Sure.
bit. So I have a question here. How do patients know that they have these treatment options? Because there's a lot that you mentioned here that many of us are not aware of as medical
Yeah.
professionals. So, is there a way that they get access to some of these treatment options?
That it's a big challenge. We are talking about this always. Um, Things that I try to do, and me and my partners try to do, is reach out to other specialties, make them aware of what we do, trying to give more talks, engage with the community, in giving talks, and trying to spread awareness. Some of these companies are trying to do more direct to the patient marketing to make them aware of these treatments, especially for some of the more common pathologies. I have That's why I also kind of make more of a presence on social media. There's even draboumehri.com, has my information as well, and I list off a lot of these advanced procedures. But we're a subspecialty within a subspecialty almost. So frankly, patients don't hear about this regularly, and they may not hear about this from their primary care provider, which is why I'm really happy to be talking about this today, to kind of just spread awareness during September Pain Awareness Month, right? So that people kind of know more about what we do.
Definitely. It's been a great pleasure to be able to utilize this platform to share what you do. And for those who are listening, Dr. Aboumehri's Instagram is it's the Pain Doc. So please give him a follow, and you can hear more and learn more about the work that he does. We would love to have you back in the future, outside of the month of September, to learn a little bit more, perhaps go a little bit more deeper into some of the things that you spoke about today. If the audience here is interested in anything specific, please feel free to reach out to Imana Education. And then, of course, we'll reach out to Dr. Aboumehri to see if he is available and interested.
Yeah,
But with
inshallah, I'd
that,
love to.
thank you so much. That'd be wonderful. We'll definitely be in contact. So for those who are here listening to the recording, thank you so much. And for those who are live, thank you so much for all of your questions. We have a ton of thank yous and jazakallahs from all of those who are listening live. So just passing that over to you. And also the same from the Imana Education. Thank you so much for being here this evening. And we look forward to having you back in the future.
Thank you so much. Assalamu alaikum.
Have a good evening. Wa alaikum salam.
Yeah.